Okay guys, here we go. Timmy's going to try to explain to you now coronary artery disease. So again, if you remember, the heart is a muscle and it requires oxygenated blood in order to contract and pump blood to your body and your lungs, right? So there are two main coronary arteries that come off the base of the aorta. So make sure that you watch that video, how the myocardium receives its blood supply, before you watch this video. All right. So remember, the aorta carries oxygenated blood, and the heart muscle itself receives oxygenated blood during ventricular diastole, or when the ventricle's relaxed, and blood flows through these main coronary arteries. Two arteries, you got your right and left main coronary artery. Now, a couple of things. Number one, arterial blood flows in a laminar fashion. And what that means is this, that within the vessel, you've got the formed elements of the blood, right? Red blood cells, white blood cells, platelets, the formed elements. And then you have the plasma of the blood that runs on the outside of the vessel. So this laminar blood flow is really critical because these formed elements can actually bump into the wall and damage the inside of the wall of the artery, the coronary artery. So many times, it's not 100% true, but many times a lot of the blockage in a coronary artery is where the artery actually splits, because these formed elements of the blood will actually bang into the walls here, and that can produce damage. So when you're looking at heart disease, one of the things you want to look at, again, is risk factors for heart disease, right? So elevated blood pressure, hypertension, right? That hypertension, that increase in pressure, that can lead to increased shear forces, meaning increased likelihood that there's going to be damage to that wall inside that artery. All right, then you got hypercholesterolemia, and if you recall, it is really the LDL cholesterol that actually forms the cholesterol plaques inside the coronary arteries. And the other thing is that it's really not necessarily LDL, but it's actually damaged LDL. And I'm not gonna, there's a big word for it, and it's called peroxidation of lipid, and specifically LDL. All you need to know basically is that LDL is what actually forms on the inside of that coronary artery. Now, what can damage LDL? Smoking, right? So smoking obviously is a risk factor for heart disease, because smoking, the tar and nicotine in cigarettes can actually damage the LDL and increase the likelihood that you're going to get it. And then diabetes, right? Obviously, these people, they have impaired metabolism, right? And without fail, almost, these people have elevated cholesterol, and specifically they have elevated LDL cholesterol. So diabetes, huge risk factor. And then age, typically after the age of 50 plus, that's going to increase your risk. Again, look, a 6-year-old doesn't bend over, pick up their marbles, and complain of chest pain, right? So this is something that happens over decades, and it doesn't become significant until the 50s and 60s, or depending on if you got a bunch of other things wrong with you, you're diabetic, smoke, drink, swear, don't read the textbook, stuff like that, that's going to obviously speed up that process. And then gender. Males have a greater risk for the development of CAD, And the reason females have a lower risk is females produce estrogen. Estrogen is protective. A couple of things. One is that it increases HDL, and estrogen is also a vasodilator. However, once women hit menopause, their risk is identical to that of a man. All right. Then there's hemochromatosis. Sounds like a song, right? Supercalifragilistic hemochromatosis. All right, maybe you sing that. Watch. Hemochromatosis is elevated iron. And elevated iron produces these things called oxyradicals. And oxyradicals are basically free-floating electrons. And free-floating electrons can damage cells. So it's typically guys, because women have a period once a month, that this increases their risk. And obesity and sedentarism, obviously people who are obese and they're sedentary, they have increased production of oxygen radicals. They also tend to eat poor, so their LDL cholesterol tends to be higher. Homocysteine levels. Homocysteine is an amino acid. And you don't get it in your diet. It's basically formed through metabolism. But high levels of homocysteine in the blood can actually damage the inside of the vessel. And then obviously family history. And this is probably the strongest indicator of whether or not you're going to get heart disease, is there's a genetic component to it. All right, so look, a couple of things you got to know, right? The coronary arteries supply oxygenated blood to the heart muscle. So how do you know that your heart, the myocardium, the heart muscle itself, requires more oxygen? How do you know the heart's working harder? Well, the answer is that you look at a person's heart rate and you look at their systolic blood pressure. If either one of these go up or both, then your heart is requiring more oxygen. And the coronary arteries have to supply that oxygen to the heart muscle, because if you can't supply enough blood flow through the coronary arteries to feed the heart muscle, then you develop a condition called ischemia. So ischemia is lack of blood flow. Infarct, myocardial infarct, is destruction of death of heart muscle. And death, right, if heart muscle is dead, it don't get better. You should write that down. So one of the things that a doctor will look at is this concept called rate pressure product. And basically it's an indirect measure of how much oxygen your heart is demanding. Now, this is important, right? So if somebody starts to get chest pain at a very low heart rate and a low systolic blood pressure, then that means the coronary artery disease is much worse, right? Because the plaque in that artery is significant enough where if they're not doing much and they're still developing that ischemia. So that's why chest pain that occurs at a higher rate pressure product is less severe than chest pain that occurs at a lower rate pressure product. So let's look at this video real quick here. So remember, the coronary arteries supply oxygenated blood to the heart muscle. All right? And then this video is going to take you on an inside look inside the coronary artery. And I'm going to open up my Epic pen. Do you know why it's called an Epic pen? Because it's epic. All right, hang on. We're going to get there. All right, something happened. I don't know what's going on. I'll just wait. Okay. So here we go. Here's the inside of the coronary artery. Now look. One of the things that has to happen, and one of the things that does happen, is you have this lining of the coronary artery. Now, when you damage that lining, right, that damage and the inner lining of the artery is called the intimal layer. When that damage occurs, and again, several things can cause it, we just talked about it, right? What's going to happen over time is LDL is going to accumulate in that area. So that damaged area is going to build up LDL over time. Now, this process actually occurs at a relatively young age. You know, in your teens and 20s, you're actually depositing LDL cholesterol. But the fact of the matter is that the heart can extract a lot of oxygen from a limited amount of blood. As a matter of fact, the heart muscle has the ability to extract about 90% of the oxygen that's delivered to it. The rest of the cells of the body can only extract about 70%. So even though the blood flow is being obstructed here with that buildup of LDL cholesterol, you don't have any symptoms because the heart is still able to get enough oxygen. But this is the important piece. Remember, we talked about that laminar blood flow, how the formed elements of the blood flow in the middle of the vessel and how the plasma forms on the end. But what's happening over time is that as that LDL cholesterol builds up, then blood flow, instead of being laminar through that coronary artery, that blood flow becomes turbulent. And that turbulent blood flow produces a blood clot. Now this is important. Remember, excuse me, it's the clot that kills you. Rarely, if ever, does a coronary artery become completely blocked with cholesterol. It's not until you get about 70% blockage in a coronary artery do you start noticing symptoms. And those symptoms that you notice are when you are really, really exerting yourself, really putting stress on that heart. So this video actually does a really nice demonstration. So not until about 70% occlusion does that person even begin to develop symptoms. So again, it's that LDL cholesterol. And then as the blood flow becomes more blocked because of the narrowing of this LDL cholesterol buildup, that blood, it's kind of like even in a highway where there's construction, right? That blood is kind of backing up. And when that blood backs up because of this obstruction, then what happens is, again, the blood flows turbulently. And that turbulent blood flow forms a clot. And any part of the heart, let's say you got a blocked artery here. Any part of the heart that's distal to that obstruction, right, that is past that obstruction, is now going to lack blood flow. So this area will become ischemic. Now, if that blood flow, or if that blood clot is not broken up, then this area of the heart will die, and they will suffer a myocardial infarct. Now, you probably know people. They've had a couple of heart attacks, right? And they're still walking around. And then there's other people that have had one heart attack and they're taking a 6-foot dirt nap. And the reason for that is that depending on which artery gets blocked, what can happen is, if you recall from when you were looking over test number 1, is that the heart has and can produce its own electrical activity, right? So those cells that produce that electrical activity need oxygen in order to make ATP. So if you happen to block a coronary artery that is supplying the electrical activity of the heart, then a nice normal heart rhythm can go into what's called ventricular fibrillation. And ventricular fibrillation is the most common cause of sudden cardiac death. So it's not the fact that your heart muscle is dead. That's not a good thing, obviously. But rather, the electrical conduction system of the heart gets jacked up and that person ends up dying. So that's why in, schools and hospitals and airports, they have the AED, the automatic external defibrillator, right? So this is ventricular fibrillation. The AED defibrillates you, and it basically works by actually stopping momentarily the electrical activity of the heart with the hopes that those electrolytes reset correctly, and then you start beating normally. One second here. Okay. All right. So let's say, for example, that a person does get a block in their coronary artery. What are the clinical manifestations, right? The signs and symptoms of someone with an impending heart attack, right? So a couple of things real quick. The spinal nerve that innervates the heart, that provides nervous sensation, pain to the heart, also supplies nervous innervation to the neck and jaw and down the left inner portion of the arm. So when one of the classic signs is obviously chest pain. Now, these people aren't going to be able to point to it because the guts are innervated differently than your skin. So the chest pain that they're going to describe is kind of diffuse. It's kind of spread out. They'll describe it as almost like a crushing type of pain. And it can, not always, it can radiate down the left arm, neck, and left side of the jaw. So you can get some left jaw pain and pain down the left arm. Now, in women, chest pain is different. Sometimes women won't even feel the chest pain, but they'll it affects them mentally and emotionally. They'll feel drained. They will feel depressed. And a lot of this information that we get on heart disease is from the Framingham study. And mostly men were looked at. So, and again, mostly men were doctors back in the day. But now women are becoming, more and more women are becoming doctors and cardiologists. So they're taking these claims of being depressed or drained or just, not feeling right seriously, and they're going to work those people up for heart attacks, right, or heart disease. Now, if someone's having an acute episode like that, then they're also going to get increased sympathetic stimulation, right? If you think you're having a heart attack or, you're having pain, why did I put symptoms? Increased sympathetic stimulation, right? Epinephrine. And what is that going to do to your heart rate and blood pressure? Well, it's going to jack it up. And now what you're doing is you're actually putting more demand on the heart. The heart has to work harder, and the blood flow is being obstructed, so it's going to make that ischemia worse. So they may be sweating profusely, they may get some nausea and vomiting. But those are the classic type of symptoms associated with heart disease. All right? Now, when a patient comes into the emergency room and they're complaining of chest pain, one of the things that you want to do is, first things you want to do is you want to, number one, slap some oxygen on them, right? And then number two is you want to give them some nitroglycerin. Now, one of the things that you'll be learning is that if an artery is not completely blocked, nitroglycerin underneath the tongue is a coronary vasodilator. Right? It's going to dilate those coronary arteries and try to increase that blood flow. But more importantly, it dilates veins. So remember that veins don't have any pressure in them. So if you dilate them, that's going to decrease venous return to the heart. And that's going to decrease the stretch of the heart. And by doing that, you're going to decrease the workload on the heart. So one of the big reasons that you give nitroglycerin is because you're going to decrease that preload. But it's a coronary vasodilator, and really it's an arterial vasodilator, right? So if you recall from watching Ohm's flow law, that you got to maintain Q. So if you give somebody an arterial vasodilator, it's going to cause the arteries to dilate, and that's going to decrease resistance to blood flow, and that's going to drop their systolic blood pressure. Now, if you don't maintain a blood pressure of at least 60 to your brain, then you're going to pass out, right? So one of the side effects of nitroglycerin can be a sudden drop in blood pressure. So you need to be careful of that. Now, you don't want to give this nitroglycerin standing up, right? Because they could pass out and hit their bean and there would be trouble. But you also don't want to give it nitroglycerin with the person flat, because if you lay them flat, remember there's no pressure in the veins, that's going to increase venous return by gravity and make the heart work harder. So you want to give that nitroglycerin to that patient sitting up, right? So if they do pass out, they just kind of slump in the chair. So nitroglycerin, coronary arterial vasodilator, an arterial vasodilator, right, in general, but it also dilates veins, so it decreases preload on the heart, and that's important. The other potential side effects are headache, right? Now, the skull is fixed, but you have arteries that line the skull and supply oxygenated blood to the skull muscle. So, or skull. And when you give nitroglycerin, it can cause those arteries to dilate and increase blood flow into your head. And that results in a pounding headache. So that's why they can get a pounding headache associated with nitroglycerin. The other thing that you want to give is you want to give morphine. And you give that for a couple of reasons. One, chest pain hurts. You should write that down. And morphine reduces anxiety in patients, right? So it's going to reduce their anxiety. And just so you know, morphine doesn't do anything for your pain per se. You still have it. You just don't care about it, right? So if you don't care about your pain, that's going to reduce your anxiety and decrease your heart rate and systolic blood pressure, and that's a good thing, right? Because that reduces the demand on the heart. The other thing is that morphine is also an arterial vasodilator. Now, if we go back real quick to why this clot was formed, hang on, right? If you look at this, the reason the clot was formed is floating around in your bloodstream are these little things called platelets. And platelets underneath the microscope look like little plates. Just like Piglet was a little pig. Now, the first thing that has to happen for a clot to form is these little platelets have to stick together. And this forms a little platelet plug. Now, you want that to happen if you cut yourself, but you don't want that to happen inside a coronary artery. So there's drugs out there that can prevent platelets from sticking together. And one of them is aspirin. So that's why you watch the commercials. Yeah, I was having a grabber, so I went to CVS and I grabbed me a bottle of Bayer aspirin and took some and then got my fatty acid to the emergency room and my life was saved. So the reason people who are at risk for coronary artery disease or have had a heart attack in the past or known coronary artery disease, they're told to take an aspirin every day because, again, it's the clot that kills you. So if you can prevent that clot from forming inside that coronary artery, you can prevent the heart attack. The other drug out there is Plavix, and that's a little more potent. And if it's really severe, doctors will try some really heavy-duty anticoagulants like Coumadin. Those are pretty rare. If you're taking Coumadin to prevent a heart attack, then there's other things going on. But what you really want to do is prevent those platelets from sticking together. So in the emergency room, they will be given aspirin. Whoops. So the other drug that they're given is some type of anticoagulant, and that's usually aspirin. All right, so it's, you want to give them oxygen, you want to give them morphine, you want to give them nitroglycerin, and then you want to give them some type of anticoagulant. So that's the initial medical management of someone who is suffering an acute myocardial infarct, or your book likes to call it acute coronary syndrome. Now, let's look at how you diagnose someone with CAD. All right. First of all, you take a medical history and you identify risk factors. And based on those risk factors, then you are going to do some screening tests. And again, you always go from least invasive to most invasive. So one of the easiest ways to do it is to get a stress test. So a stress test, basically what it does is that it increases myocardial oxygen demand, right? If you are working harder, if you're exercising, that means your heart rate is going to go up and your systolic blood pressure is going to go up. And that means the heart requires more oxygen. What are the vessels that supply the oxygenated blood to the heart muscle? Well, those are the coronary arteries. So when coronary artery supply meets coronary artery demand, then you're straight, right? Things are good. But if you have a situation where coronary artery supply is less than coronary artery demand, meaning you cannot supply the amount of oxygenated blood to that heart muscle that the heart is demanding, then that you get ischemia. Right? Lack of blood flow. And how ischemia is interpreted on an EKG is ST segment depression. So this right here, from here to here, this is the ST segment. And normally, most EKGs, this, I'm going to try to draw a straight line if I can. This is the baseline. So the ST segment should be at baseline, and that's pretty close, right? So there's no evidence of ischemia. Now you get the person on a treadmill, they start working harder, so their heart rate and blood pressure is going up, so you know that the heart is working harder, so it's demanding more oxygen. And what can happen is that if you cannot supply that oxygenated blood to the heart muscle because there's cholesterol buildup in that particular coronary artery, then it is revealed, if this is the baseline right here, as you can see, the ST segment drops below the baseline. So ST segment depression is a sign of ischemia, and it can be revealed by performing a stress test. So, and this is really important, the lower your heart rate and systolic blood pressure, the lower that is, and ST segment depression occurs, then the more narrow, the more blocked that coronary artery is. So that means the heart doesn't have to demand that much more oxygen before you start seeing changes on the EKG and indications of ischemia. So if someone is experiencing some EKG changes on a stress test, then they just don't bring them in for bypass surgery. They will do the next test, and that next test is diagnostic. And one of the best diagnostic tests is using a stress test with thallium. And thallium is taken up by healthy cells, and it's actually taken up by the sodium-potassium pump. And then right after you're done with the stress test, they inject the thallium at peak exercise, and then they will scan your heart. And the thallium shows up in healthy parts of the heart. If the cell is lacking oxygen, then it's not going to be able to make ATP, and you know that sodium-potassium pump needs to go, so the areas of the heart will show up as being dark. Then what you have to do is you have to sit around for about 3 or 4 hours, and they come back and they scan you again to see if those dark areas lit up again. And if they lit up again, then you know that they were slowly taking in the thallium, and that may be a sign of ischemia. But if they don't take up any of that thallium, then that part of the heart is dead. Now, if that's positive, then what they're going to do is they're going to do an angiogram. So what they're going to do is put a catheter into you and put you under a fluoroscope, essentially. And they're going to inject some contrast dye. And as you can see here, you have, these are the coronary arteries, and they're nice and open. And then here, if you look, you can see where there's plaque buildup and narrowing. Now, if they identify these narrow coronary arteries, the cholesterol buildup, then what they do is an angioplasty. So essentially what they do is, and a lot of times they'll do the, whoops, a lot of times what they'll do, excuse me, is they will do the angiogram, and if they identify something, they can do the angioplasty right there. So they're going to thread it into the coronary arteries. Then they're going to, once they've identified the plaque, they thread a guide wire, and then they thread the balloon over it. So once the balloon is in place, they inflate the balloon and they smash the plaque into the walls of the coronary arteries, opening it up. And now what they're using is a stent. And basically, it's a little, almost looks like a little spring on a pen. And basically what happens is the stent is over the balloon, and then they will smash that plaque into it, and then the stent remains in place. So here's the video of it. Now this is much more non-invasive than cutting somebody's chest open and then doing bypass surgery. And that stent will remain in place. And basically what it does is it prevents the coronary artery from spasming and from blocking off again. Now it can, obviously, but what they do is they also put an anticoagulant. They coat that stent with that anticoagulant to make sure that blood clots don't form. All right, now there's some other diagnostic testing for heart disease. Echo, for example. Now, echocardiogram, just so you know, looks at structures of the heart and blood flow. So it can't analyze coronary arteries. So it looks at structures of the heart, right? It looks at wall thickness, how much blood is being ejected per beat, how big the chambers are. Is there enlargement? Is there hypertrophy? Is there damaged valves? So again, echocardiogram looks at the structure of the heart. There's also some pharmacological stress testing, persantin and dobutamine, that take advantage of using drugs that mimic the sympathetic nervous system or that are arterial vasodilators to help them diagnose it. Now, look, if somebody comes into the emergency room and they're complaining of chest pain, if you recall, and I tried to explain this to you, different cells do different things, right? So they're going to have different proteins inside them. So if you got the blood here and then you got a heart cell, remember that when they draw your blood, right, they stick a needle in there, they're checking for stuff in the blood, just in the blood. So if your heart cells are healthy, they have a healthy cell membrane. So all of the heart proteins, right, are going to be in a heart cell. So when they check your blood, they shouldn't find any heart proteins in there if your heart is good. But if you're ischemic or you've had a heart attack, that's going to cause the cell membrane to lyse, right, break down, and the heart proteins are going to go into the blood. And the amount of heart proteins that go into the blood give the doctor an idea of the size of the heart attack, right? The size of the myocardial infarct. So that's how doctors, after a few hours, if someone comes in the emergency room, they can talk to the family and say, look, they had a big heart attack, or, don't worry about it, they only had a little heart attack. So these are the common chemical markers for heart attack. Now, you've got these proteins in other cells, but the one protein that you have that's kind of exclusive to heart cells is troponin I. So troponin I now is kind of the gold standard in terms of looking at heart disease. The other one is troponin T. Myoglobin is basically a protein that kind of stores oxygen inside the cell. And the heart has a lot of myoglobin, so if heart cells die, they're going to dump it into the blood. Then there's a total CK. I don't want to talk about that. This is what I want to talk about. CKMB. CK stands for creatine phosphokinase. It's an enzyme that is in muscle cells, but the MB fraction is specific for heart. So if that is elevated in the blood, then there's a good chance you had a heart attack. But troponin I and troponin T now are becoming, again, the gold standard for heart disease. Okay, so let's look at the difference, again, between ischemia and infarct, right? Death of heart muscle. Now, remember, ischemia or lack of blood flow. That doesn't mean that the coronary artery is completely blocked with a blood clot. What it means is that the demand that the heart is asking for, you can't supply it with that blood. So if you have a person and they're walking up a flight of stairs and they get chest pain, if they sit down and their chest pain goes away, then that's ischemia. If they do that and they sit down and they rest and their heart rate and blood pressure drop, but they're still having chest pain, that could be an indication that they've completely blocked a coronary artery and they're going to have a heart attack, a myocardial infarct. And the EKG changes that are associated with infarct is ST segment elevation. So ST segment elevation is a sign of myocardial infarct or a complete block of a coronary artery. Now, again, here you have the baseline, roughly. And as you can see, the ST segment is elevated above the baseline. Some of you have maybe heard this as the fireman sign. Right? Right, it looks like a fireman's hat. Or tombstone T-waves. Right, rest in peace. Basically what that means is that person has suffered a myocardial infarct, and this is the important piece. They have completely blocked a coronary artery. And unless that artery is unblocked in a relatively short period of time, typically about 4 to 6 hours, the area that coronary artery supplying is going to die. So if doctors suspect that and those heart cells are dead and they die, then those heart proteins that we talked about are going to end up going in the blood. And the higher those heart proteins, the bigger the MI. Now, what do you do for someone after they've had a heart attack? All right, they're recovering. They survived the heart attack. What do you what types of medicines you want to put them on, right? So number one, first and foremost, are beta blockers. Beta blockers, and if you say block beta, that ain't right. Beta blockers block beta receptors in your heart. And specifically beta 1 receptors. Now, if you watch the video on the function of beta receptors, when epinephrine binds to beta receptors in the heart, it's going to increase your heart rate, and it's going to increase the force of contraction of your heart. And if you increase the force of contraction, then you're going to increase systolic blood pressure, both of which is going to increase the amount of oxygen required by the heart. So you certainly don't want to make your heart work hard. So by giving them beta blockers, that's going to lower their heart rate and lower the force of contraction and lower the oxygen demand placed on the heart. Now, what caused this problem, right? What caused it is LDL cholesterol building up, right? So you don't want them to have a super high LDL, right? So you give them a statin. So those statin drugs decrease the production of LDL cholesterol by the liver. Zocor, Lipitor, Crestor. So they're going to be on a beta blocker, they're going to be on a statin drug, and they're also going to be given nitroglycerin, right? And that's usually under the tongue. And they're told that you can take a nitroglycerin if you're experiencing chest pain, and you can take one every 5 minutes. But after the third one, if the chest pain remains at rest, then you need to get your fatty acid to the ER, because it's not ischemia. It could be an infarct. And then they're also going to be on some type of anticoagulant. And depending on if they've had a heart attack in the past, maybe Plavix, but some type of anticoagulant to prevent the formation of that blood clot inside that vessel. So those are really the drugs to manage someone who's had post-MI or who's at risk for developing a heart attack. I hope it helped.